Tonight's lecture shouldn't take too terribly long. These are all three pretty quick chapters. Uh, if y'all have any questions, please stop, interrupt, and ask me these questions. First chapter we're going to go over is chapter 11, scene size up. So there's a host of things you've got to do as you're approaching a scene. First and foremost, you need to ensure that the scene is safe. So you need to make sure there's no sort of factors around that's going to prohibit you from operating safely. Now, whether that is an environmental factor such as hanging tree limbs, hanging power lines, something on fire, or non-environmental factors, whether that's somebody who's being violent, aggressive, uh, people walking back and forth, slinging guns around that may not even be part of your scene, but they're just it's not making it safe for you. So you always need to make sure that what you're seeing is safe before you enter it. Next thing you got to do is take your standard precautions. What are your standard precautions?
Your PPE.
PPE, right? So your gloves, your mask, your goggles, whatever your gowns, whatever you need to be wearing for that particular call. So you need to note the mechanism of injury or the nature of the illness, depending on whether it's a traumatic injury or a medical type call. Figure out how many patients you have, and then based on that, decide what additional resources you may need. So, do you have two patients, but they're both very minor and you can take care of both of them, no problem? Or do you have 15 patients and you need, the daggum National Guard to respond to your location? What do you need? Figure out what you've got, figure out what you need coming to you. The only predictable thing about an emergency is that it is unpredictable and it can pose many dangers. Scenes are rapidly evolving. Things can go to hell in a handbasket very quickly. It's always important to maintain a constant level of vigilance, a constant state of awareness, keep your head on a swivel the entire time you're on an emergency scene. So, for instance, if you approach a collision scene or a car accident scene, look and listen for other emergency units approaching. Please do not get run over by your own units. It's embarrassing. Uh, Look for signs of a collision related power outage. So look around. Do the houses surrounding this collision have power? If they don't, there may be some power lines down, right? Make sure we don't step on one of those. Observe the traffic flow. See, where the areas of traffic are stopped at. See if they're creeping by. See if they're still moving. And then look for smoke in the direction of a collision scene. Is the vehicle on fire? Do we need to get an engine in route if they're not already, right? As you get inside of the scene, look for any clues that are indicating an escaped hazardous material. What might some of those clues be? What might be an indicator you're approaching a hazmat scene?
Orange smoke.
Orange smoke, that's probably a pretty bad sign, and I'm probably going to stop right where I'm at and back up. Uh, yeah, so I mean, oddly colored smoke, uh, a tanker truck is probably a pretty good indication, something with placards on it. If it's a placarded scene, you need to stop right where you're at as soon as you get inside of the placard and pull out your emergency response guidebook and figure out what that placard means. And we're going to go over that in hazmat, towards the end of the class. But uh, look for collision victims on or near the road. Make sure you don't run over somebody. It's happened. It's once again, it's embarrassing. Uh, and it's not good for your patients, obviously. I mean, we don't want to, our main goal is to not make things worse and get them the help they need. So make sure you don't add to the problem. Uh, look for any smoke that you may not have seen in a distance. Uh, and then again, look for broken utility poles and down wires. Make sure you don't get yourself wrapped up in a bad situation. Make sure or be alert of persons that are walking alongside the road towards the collision scene. Make sure people aren't trying to enter your scene and disrupt it or cause havoc or cause further harm. And then watch for signals of police officers or other emergency service personnel. So oftentimes somebody may beat you to the scene. So watch for their signals. They will oftentimes, if they're worth their salt, they've already done a little bit of an assessment, a little bit of a size up, and they know where they want you at. So watch to see where they're watch to see where they want you to pull up at. Once you get on scene, follow the instructions of the person in charge, command. If you are the first person there, then you assume command. You are now the person in charge. Uh, Make sure you take appropriate PPE. Depending on what the needs are of the scene, that may include a helmet and turnouts, or that may include just your regular BSI and a reflective vest. If you're out on the side of the road working on anywhere near the flow of traffic, you need to always wear a reflective vest. When you're approaching a vehicle collision, you're going to establish a danger zone. So a danger zone is kind of like a buffer zone, gives you room to work, right? If there's no apparent hazards, you want to have at least 50 feet in all directions. Make sure you have a good clear buffer around that accident scene for you to work at. If there's fuel spill or some other hazard, you want to try and push that to at least 100 feet or more, depending on what the needs of the accident are. Give yourself a good big buffer zone to work with. Same deal with the vehicle's on fire, at least 100 feet in all directions. If your vehicle's on fire and you're in an ambulance, there's not a whole lot you can do till the engine gets there, right? So don't go up in there trying with your fire extinguisher trying to play Ricky Rescue because it's not going to work. If wires are down, stay away from the down wires. Back up and give at least one full span of wire length away from the pole. Uh, just make sure they don't, because they can arc, they can spark, they can move. They're energized, right? Make sure you don't get into a bad situation with that. And then if there's a hazmat scene involved, make sure you reference your ERG. So you're going to look at those placards and match that to what's in your ERG. There should be an ERG in every ambulance. Then we're going to go over how to use those in a different class. On other scenes, you may be called to what may end up turning into a crime scene. So you want to always, as you approach, evaluate for any kind of threat of violence. Are there people fighting? Are there people yelling, shouting at each other? Uh, do you see weapons that are visible? Somebody carrying a gun, somebody pointing a gun at somebody, somebody same with a knife or a bat or some sort of other type of club. Uh, look for signs of alcohol or other drug use. Where the person's impaired or intoxicated. Look for any kind of unusual silence. Everybody knows what that awkward, eerie kind of silence is. If you got that bad feeling, take note of that. Or if you have knowledge of prior violence at the scene, there's times where we run on the same people often, and we know that they can be violent or combative with responders. So take note of that. If you if you suspect any of this, if there's any kind of threat of violence at all, you back out and you stage away from the scene. If you're notified before you get on scene that there's a threat of violence, you stage in the area, wait for law enforcement to get there. If you, as you pull up, you encounter one of these signs or something just doesn't feel right, you just don't feel safe, it's not comfortable, back out and call for law enforcement. Stage a good ways away from the scene and let law enforcement get there and secure it, and then they will call for you back in once it's safe.
Jake, I got a question real quick.
Yes, sir.
So, as far as the legality goes with backing out of the scene, if it's not the patient that's being harmful to the EMS workers, like and somebody like walks like if say somebody walked up into the house and started causing problems, or was a family member causing problems, and the patient is what could be considered terminal, I guess. What's the legality like if we had to leave that patient and the patient ended up dying?
Okay. I'm going to pose a question back at you. If you stayed and you got hurt and you became a patient yourself, are you really helping that patient anyways?
No, sir.
Okay. Your safety and the safety of your partner is paramount above all else. It is your safety, then your partner's safety, and then the safety of your patient. Reason being is you can't help anybody if you are injured or killed in the process of trying to do so. You don't have to worry about collecting equipment. You don't have to worry about collecting the patient. I've left bags and monitors in houses before because somebody started chasing me with a knife. Okay, you get out of there. Law enforcement will get there pretty quickly. They'll come back in and they'll handle the problem. You can be brought back in. Now, if you can safely extract the patient while you leave, do that. But if it's going to create a hazard for you to try and get the patient out of there, we can't help them if we get injured or killed, right? So there's not a right answer to any of those situations. You just got to evaluate those situations and see what you can do, what you can't do. As the person's causing the safety hazard, are they threatening you, or are they just getting into it with somebody else in the house in the proximity of y'all? If that's the case, you might be able to slip away with the patient, right? But if they're directly coming at you or your partner or something like that, y'all just need to get out of there.
Copy.
All right. So your standard precautions. You'll hear it called PPE. You'll hear it called BSI. So your standard precautions are the minimum equipment that you or the minimum protective equipment you wear every time on every call. Usually that's going to be gloves. Some areas require you to wear safety glasses. So in that case, it's going to be gloves and safety glasses. Uh, so make sure you always have your standard precautions with you and wearing them to protect yourself. So your nature of call, your nature of illness, your mechanism of injury. So that's what you pull up and you determine why EMS has been called. And you're going to see all these terms again very soon when we start going over that medical assessment sheet next week. You're going to determine why EMS has been called. So figure out the mechanism of injury, like what caused them to be injured, or their nature of illness. Why are they sick? What's going on with them? Are they having shortness of breath? Are they having chest pain? Are they having abdominal pain? Are they nauseous? What's the nature of the illness? What's going on? Figure out why you're there. Your mechanism of injury is any force that may have caused an injury. If you understand how some of these forces work, you can kind of predict what injuries they may have. For instance, if you know how a little bit of how some force works, somebody that's been struck very hard in a rear end collision, you may be looking for some sort of whiplash type injury, right? Uh, you understand that if you approach the scene and there's like a starring pattern on the windshield, then they may have struck their head on the windshield, so maybe you need to be cautious of a head injury, right? So just understanding how some of that stuff works, that simple physics, how that works, can help you kind of predict what you need to assess with your patient. For instance, with a head-on collision, you may have an up and over injury or a down and under injury, meaning they went up and over the steering wheel or down and under the seatbelt, right? So that tells you kind of where to look at, depending on how you found the patient. If they're kind of slid down, you're going to check around their abdomen, make sure that the seatbelt didn't catch or lock or pull on anything down there. If they went up and over, you want to check around the chest for the same reason. That's that starring I was telling you about right there. That's an indication they may have hit their head. And you get into like falls. So adults fall of more than 20 feet uh, on an adult is considered a major trauma. Same deal with a child under 15, a fall of more than 10 feet or 2 to 3 times the child's height. That's considered a major injury. That's where you start having potential to have a lot of subsequent injuries as well. Uh, Characteristics of fall may provide clues to a patient's injuries. So if you find somebody that's in a construction site that's just laid out and you just get called for a man down, they're laid out in a construction site. But you see all this up here, right? There's probably scaffolding somewhere outside of the view. You see where they're working on a second story up here. It's reasonable to assume until we know otherwise that he might have fallen from the highest point of that structure, right? So we need to make sure that we take note of any kind of potential injuries he may have from that. When working on patients who have fallen, things you need to gather. You need to figure out how high they fell from. Did they just fall from standing? Did they fall off of something? Did they fall off a piece of furniture? Did they fall off a roof? Uh, where did they fall from? And then figure out what they fell onto. Good news is most of the time they're still gonna be laying on it. You can take note of it right there. Did they fall on dirt? Did they fall on grass? Did they fall into water? Did they fall on concrete? What did they fall on? What part of the patient hit the surface first? Did they land flat-footed? Did they land on their back? Did they land on their butt? Did they land on their side, their face? Figure out what they landed on. Was there anything that interrupted the fall during it? Did they hit something before they hit the ground? Figure that out and make sure you can take note of all that. So those are going to be important for assessing the injuries later on as you get further into your patient assessment.
So, Jake, I have a question.
Yes, sir.
So, this actually happened last year on a job site I was on. We're on a bridge. One of my guys fell 20 feet off a bridge and they landed on an embankment. He landed on his left side. He had broken arm, both his shoulders were torn, broken ribs, but from the way he landed, it looked like he landed on his head, but he didn't have a concussion, and whenever he came to, he still knew like where he was at. He answered all his questions and everything. Why would that not be, why wouldn't he have any type of confusion or anything from that type of
So
mechanism of injury or such
it
that
depends.
traumatic?
Uh, if he didn't actually hit his head, there's probably nothing there to cause any kind of confusion or any kind of issues like that. Some people can have a concussion and still not be confused. So he may still have had a concussion. Say he did hit his head or something like that, and he may just not have been confused. Uh,
Even though he was knocked unconscious?
he may still come to and not be confused about anything. It happens. There's no such thing as cookie cutter medicine, right? So we can give you tools to assess and figure out, what to look for and what to do about it. But there's a lot of things that people will respond to differently than other people. Uh, for example, I fell out of a second story window on the fire department one time, landed on my face, had a concussion, but I didn't get knocked out, right? And I wasn't confused, I wasn't dizzy or anything like that. Where, if that happened to somebody else, maybe it's the same fall, maybe it just was a different person, right? And it impacted them. Maybe they did get knocked out. Maybe they did have confusion, concussion. So there's two people that may experience the same type of injury, but may react to it totally differently. It's just how our bodies are structured, right? So there's
Hmm.
not really a good right or wrong answer to why he did or didn't have confusion. It's just that's just how his body, compensated and everything else. And he didn't, it did that little reset right there where he went unconscious, but that was about it.
Okay. Hmm.
Any other questions? So you have penetrating trauma. Maybe something maybe called for a injury with penetrating trauma. And penetrating trauma is anytime a injury is caused by something that passes through the skin or breaks the skin or the body of the tissues. Uh, the severity of it is usually classified by the velocity of the item that caused the injury. So stab wound versus gunshot versus flying debris versus whatever caused the penetrating wound, right? So you have your low velocity injuries, so such as a knife. Damage is usually going to be limited to the area that's penetrated. There may be multiple wounds, especially with a stabbing. A lot of times, a stabbing occurs in a frenzy where they hit over and over and over again. Uh, but usually, with it being low velocity, the damage is going to be limited to around the stab wound, right? There's not a whole lot of impact there. There's just the blade sliding in. Where you have your medium and high velocity, which is your handgun or your rifle or shotgun, respectively. Uh, those injuries may occur anywhere in the body. So there'll be damage directly from the projectile, but there's also going to be pressure related damage with these uh, cavitation. So you got to think. Anybody ever watched videos of like something gets shot, like ballistic gel getting shot, stuff like that? Anybody?
Yeah.
I'll post a video. Well, if you watch, there's different videos where they may test out different weapons and stuff like that. Where they shoot a block of ballistic gel. A lot of times they'll go into slow motion as the bullet hits the ballistic gel. But you can watch the ballistic gel vibrate, shake, and cavitate side to side. The same thing happens to your body when it's hit. Okay, so same thing may happen to one of your patients. Say they got shot with a handgun. Well, yeah, they're gonna have the wound directly from the projectile. They're gonna have the penetrating wound where it hit. They may also have a pressure related wound. So they may have an injury to their diaphragm or their lung or somewhere other in their body from the cavitation from the pressure, also causing that injury. Does that make sense? Okay. Other types of mechanism of injury is blunt force trauma. It's any injury caused by a blow strikes the body but does not penetrate the skin. Uh, Signs are often subtle, easily overlooked. You want to maintain a high index of suspicion based on your mechanism of injury. So, and oftentimes you'll see bruising or minor abrasions or stuff like that with blunt force trauma type injuries. Pretty much anything that does not penetrate is a blunt force injury. Any questions so far? So likewise, as you have mechanism of injury, you also have nature of illness. So nature of illness is going to be the reason the patient called EMS. on a non-injury type scene. So you begin identifying the patient's illness during the scene size up. You scan the entire scene. You see what you see how the patient presents, you see everything you can see as you walk up. Start painting a picture in your head. Uh, look for any additional patients. Information may be obtained from several sources, whether that's the patient, could be a family member, a bystander, it could be a scene. What type of information might you obtain from a scene?
Everything's laid out.
Everything's laid out, right? For instance, do you show up to a house, somebody's unconscious, and there's an empty pill bottle? What are we going to suspect there? Possible overdose, right? So just take a look at everything around you, ask questions. The best person to ask is the patient, but if the patient's not able to ask a family member, ask a bystander, ask a friend, right? Assess your number of patients. So how many patients are present? Uh, do we have enough resources on hand to care for all of these patients? It's like I said earlier, you may have two patients, but they're both, minor injuries or minor illnesses. You can handle both of them with one ambulance, right? Or you may have 15 patients and you need the National Guard. Just figure out what you have to take care of this scene. Anybody have any questions over scene size up? Comments, concerns, donations? Next chapter is going to cover the primary assessment. So your primary assessment can essentially be boiled down to your initial assessment that focuses on life threats. So A, B, C, or airway, breathing, circulation. That's the core component of your primary assessment. The order in which you approach these may vary depending on the patient's condition, what you see immediately during your size up as you approach, how many EMTs are on the scene, or any other priorities you determine as you go through your assessment. For instance, if I, you know, we're assessing ABC on everybody, but if I walk up and somebody is, been in a motorcycle accident, they're bleeding profusely from their leg and they're screaming that it's hurting. Okay, well, A and B are checked. Okay, I can go straight to C, right? I can stop the bleeding. Okay. So the order you approach that may vary depending on the type of patient you're dealing with. So the sequence will vary. So if the patient has signs of life, meaning they're either conscious or they're pink or whatever, you can see their breathing. This goes A, B, C. Uh, if the patient appears lifeless or they're in cardiac arrest, they have no pulse, then it's C, A, B. So airway, breathing, circulation with signs of life, or circulation, airway, breathing if there is no signs of life. Why do you think that it changes if there's no signs of life? What do we do if somebody has no pulse?
CPR.
CPR. You do chest compressions, right? What is Which one of these does chest compressions most affect? Does it affect airway, breathing, or circulation?
Circulation.
Circulation, right. So the patient appears lifeless, no pulse. We start with circulation. We start that CPR. We get that going. So as you make decisions as you're doing your primary assessment, you see what kind of immediate interventions need to be done. For instance, if you notice any vomit in the airway, uh, that's very serious. That needs to be taken care of immediately. So suction, makes suction a priority before you continue to do anything else. We may suction the airway, maintain that airway. For example, likewise, there's big word bleeding. That's just a lot of bleeding. Okay, that's a big fancy word for a lot of bleeding, and I'm not going to embarrass myself by trying to pronounce it. So, yeah, you see very serious bleeding, a lot of bleeding going on. That must be stopped immediately. Otherwise, the patient's going to die. So things can happen before you proceed further into your assessment. When I was going through EMT school, my instructor put it like this: air goes in and out, blood goes round and round. Any variation thereof is a problem and needs to be fixed immediately before you do anything else. During your primary assessment, you note that there's no serious interventions need to happen, so you don't have to control bleeding. You don't have to do CPR. You can switch kind of into a less urgent mode and start proceeding further into your assessment. For example, you may start administering oxygen for that's appropriate for the patient's condition. You may start evaluating for shock. You may start into your secondary assessment after that. Other parts of your primary assessment is going to be your general impression. So your general impression is kind of what do you see as you walk up? How does the patient look as you approach? Do they look sick? Do they not look sick? Are they pale? Are they hunched over? Are they screaming in pain? Is their face contorted in pain? Are they breathing really fast? Are they breathing really shallow? How do they look when you walk up? Then you assess their mental status. Uh, Ask them questions, figure out if they know the answers to the questions that everybody would know. Some simple questions that I always ask are, what year is it? What county are we in? Or what city are we in, depending on where we're at? Who's the president? What's 5 + 3? Just simple things that most people would know. And that will kind of help give you a baseline of where their mental status is. You assess their airway. Is their airway open? Is their airway blocked? If their airway is blocked by something, whether it's vomitus or some sort of other obstruction, we need to clear that. Whether that's through suctioning or the Heimlich maneuver, CPR, or whatever the case may be, we need to clear their airway, get it open if it needs to be cleared. If it's already open, we make sure it stays open. We assess breathing. How is their breathing? Are they breathing fast? Are they breathing slow? Are they breathing shallow? Are they breathing at all? And then make any kind of interventions there as necessary. Assess their circulation. So how are we going to assess their circulation? What's something we will do to assess their circulation? Somebody? Anybody?
Blood pressure.
Blood pressure is one. Pulse is one. Capillary refill. All sorts of ways we can quickly assess circulation. The quickest way usually is just to feel a radial pulse. Check a quick radial pulse. I usually will also do that as I walk up. I'll introduce myself. I'll start asking questions. What's going on today? And as I'm doing that, I just reach over and I gently take a radial pulse as I'm talking to them, making that initial contact with them. Like I said, your general impression is kind of your patient's chief complaint and their appearance. How do they look? What's going on with them? What they say is going on with them. Helps determine the patient's severity. There's times you walk in, you're just like, ah, crap, this guy looks sick. We got to go. Helps sets priority for care and transport. Is this kind of a stay and play or is this a load and go? Are we going to sit in here for a minute and do a little more thorough, down and detailed assessment? Or is this down and dirty? We're packing them up and we're getting out of here right now. We're going to apply some hypo diesel and get them to the hospital. Which one are we doing? Always do the best you can to treat a patient's life-threatening condition without aggravating a potential spine injury. Once you're able to do so, once you've ensured all ABCs are intact and everything else, if it's indicated, meaning you have a head or a neck injury or potential for a head or a neck injury, uh, you want to immobilize the spine manually. I mean, somebody will hold C-spine, somebody else can apply a cervical collar. And you want to continue, once you start spinal motion restriction, you want to continue it throughout the call unless physical examination determines it's not necessary. So unless throughout the course of your assessment, you determine that they do not have a very high index of suspicion to have a spinal injury, it can be discontinued. So the manual stabilization, that's what I was talking about earlier, holding the head in a inline neutral position. And there's different guidelines depending on your service, the kind of protocols of when to use manual stabilization, when not to. when to take, when to apply C-collar, when not to apply C-collar, and things like that. We'll go over that more as we start getting into the trauma chapters. So you may do something called a look test. Look test kind of help you identify patients who may be critical. If the patient appears lifeless, check a pulse. If they don't have a pulse, start CPR. Prepare your AED as soon as possible. Uh, you may identify quickly a patient has obviously altered mental status. So they're speaking nonsense or they're just in and out of consciousness or whatever the case may be. Uh, you can also just look and identify somebody who's very anxious or who's very pale, sweaty. You just kind of get a general impression of how do they look? What do you think's going on with them? How do they look to you? Do they look okay? Do they not look okay? Look for any kind of specific position they may be in. So tripod position, which where they're leaning on their knees and trying to do their best to breathe. Talked about it a little bit during airway last week. Levine sign, which is where they're kind of clutching at their chest. That may indicate obviously chest pain or discomfort. Just see what you can see as you walk up. Sometimes just a quick survey of the room, the scene is very beneficial in furthering your assessment. The chief complaint is going to be what the patient says they called you for, what the patient says is going on with them. They may be specific and they may say, I'm having abdominal pain or my stomach hurts. That may be vague, just be like, I wasn't feeling good. That's where you're going to have to dig a little further. Okay, well, what doesn't feel good about you? Tell me a little bit more about what's going on. As you assess their mental status, there's an acronym that you need to remember. Everybody needs to write it down. It's called AVPU, AVPU. It stands for alert, which means they are oriented to person, place, time. They can answer questions, they can talk, they can look around, they can track. Verbal response means that they will react to a loud verbal stimuli. So, they're kind of slunched over or kind of going in and out, consciousness and everything else, but you can shout and they will kind of perk to and look around a little bit and then start going back out. And you can shout and they can perk to and go in and out a little bit. If they're responsible only to loud verbal stimuli, means they are a V on the AVPU scale. Painful response is when they're only responsible to painful stimuli. So they may not be alert, they may not respond when you shout, but you may do a sternum rub, or you may pinch their fingernail, or do a trap squeeze, or some sort of painful stimuli, and they come alive. They kind of groan or pull away from you, or they may look around a second and go back out. That means they're responsive to painful stimuli only. And then U is unresponsive. It means it doesn't matter what you do. You could rear back, slap the crap out of them. Don't do that, but you could, and they wouldn't do anything, right? They're unresponsive to any and all stimuli. Everybody got AVPU? I talked about this earlier. So as you approach, you look for signs of life, including movement. Is the patient moving? Are they breathing? Do you see chest rise and fall? If you don't see signs of life such as breathing, check a pulse. Do they still have a pulse? Do they have a pulse? Do they not have a pulse? Do we need to just bag them? Do we need to do CPR and bag them? If you approach the patient and they're alert, talking clearly, or crying loudly, then it's safe to assume the airway is open. The airway is not open or it's in danger, take measures to open it, clear any blockages, like I said, suction, Heimlich, CPR, like I talked about earlier. Patient may require breathing assistance if they are in respiratory arrest but still have a pulse, meaning they're not breathing, they still have a pulse. We have to provide rescue breaths like y'all practice on Saturday. Maybe they're not alert with inadequate breathing, so they're breathing very, very shallow or very slow. We may need to start assisting their ventilations. May have some level of alertness with inadequate breathing. Maybe we need to kind of coach them into breathing a little bit better, or we may need to take over and assist them with their respirations. Or they may have adequate breathing, but may have signs of respiratory distress or hypoxia, so we may need to provide supplemental oxygen. When you're assessing circulation, some things you're going to look for, you're going to assess the skin. So good circulation is, they have the appropriate skin color, temperature, dexterity, everything else. So it's warm, pink, and dry. That's good circulation. Some signs of shock may mean that they are pale and clammy. So their skin's very pale, they're very sweaty, they're clammy. Maybe signs that they may be kind of in shock. And check for a pulse. If they're conscious, you check a radial pulse. If they're unconscious, you always go straight for a carotid. Maybe three results of assessing the pulse. It may be within normal limits. It's right on the money, right where it should be, or maybe a little fast or a little slow, but nothing really concerning. Or maybe unusually slow, which is where you feel a beat every so often, or unusually fast where you feel it and you can just feel it just thumping away. And then obviously when you assess circulation, you're going to check for and control any kind of severe bleeding that you run across. You treat any threats to the ABCs as soon as you discover them. You don't stop and come back to it. If you see it, you deal with it right then. You want to also make sure you determine the priority of the patient. So a stable patient is going to have normal vital signs or relatively normal vital signs, uh, no immediate threats to the ABCs, and they can sustain transport for a little while. If the patient has any kind of threat to the ABCs, whether they're actual or it's imminent, you think it's coming, that rules out they're stable, they're automatically an unstable patient. A patient's priority can change. You may not always know what the problem with the patient is, especially if they're altered or unconscious. It's going to be up to you to look at them and get kind of that gut feeling going on based on what you know and what your assessment results show to determine whether they're stable or unstable. And a patient's priority can change. You may have a stable patient that becomes unstable, that maybe goes unconscious on you, or maybe starts having respiratory issues, or maybe maybe goes into cardiac arrest. They change from stable to unstable very quickly. If you have any kind of life-threatening problem, you want to initiate priority transport then. We can continue assessments in the ambulance. We can continue definitive treatments in the ambulance. But if you have a life-threatening issue, it is not a stay and play, it's a load and go. Deal with the life threat right then, and then load them up and transport. You can continue your assessment and your care en route. You can reassess and continue care en route. But it's most important that you get them to a higher level of care as fast as possible. Maybe questions so far? So your primary assessment may take on a different form depending on your patient. So the patient may have some sort of underlying medical problem or underlying injury that may not be why you're there today, but you still have to deal with that in some capacity, right? Or the patient may or may not have an altered mental status. If they do not have an altered mental status, means they're alert and oriented, then you can ask them all the questions until the cows come home. You can ask them anything you ever want to know about them, right? And they can answer you and give you good answers, or they may be altered, they may be confused, they may be in and out of consciousness, and you may not be able to get a lot of information out of them. We're going to rely on your physical assessment skills. Your patient may be an adult, a child, or an infant. What's the difference between assessing a child and assessing an adult? Bueller, Bueller. What do y'all think would be the difference? Start picking on people here in a second.
Can you repeat that question one more time?
So you just weren't paying attention. I got no, I'm just What do you think the difference between assessing an adult or assessing a child would be?
Children, I've noticed if I've run on calls with children before, they seem to shy away from you and they may cling to the parents. Whereas an adult, they'll just tell you straight up what they feel like what's going on.
Right.
So,
You're absolutely right. So you're a stranger, right? The kid doesn't know you usually. They're already in a bad way. They're already not feeling good or they're already hurt. And now they've got strangers talking to them, right? And they got strangers asking them a bunch of questions. They've got strangers feeling on them and touching on them, right? They may shy away from it. Whereas with an adult, you can just ask them questions, like he said, and they give you the answers. So how may we assess a child then? Well, maybe an easier way to assess a child.
The child may be more comfortable with communicating with their parent, mom, dad, aunt, uncle. So maybe have the parents ask the same questions you're asking, or maybe maybe kind of get on, not necessarily their level, but just kind of like how you would like normally like treat kids, kind of like, oh, this
No,
kind
you're
of go
absolutely
that
right.
way.
You do get on their level. So you don't ever want to be towering over them. You
Yeah,
don't
you
want to
want to
squat
want
down
to
and
like,
get, yeah,
yeah,
you'll
squat
squat
down and
down and
get
get on
on.
their level. What I'll oftentimes will do is I'll have the parent kind of hold the child, have the child sit on their lap, hold them, whatever else. While I have to do, if I have to do some sort of physical assessment, I'll have the parent hold the child, especially if the child is anxious. If this kid is, happy-go-lucky, happy for me to be there, then we usually don't have a problem. But if the child is anxious, nervous, have the parent hold the child. Very good. And same deal goes for an infant. An infant obviously can't speak for itself, so you're gonna have to direct all of the questions to the parent, and then just rely on your physical assessment skills when you're looking at the infant. Very good. Anybody have any questions over primary assessment? Comments, concerns, donations? Last chapter we're gonna go over tonight is vital signs and monitoring devices. Y'all pay extra close attention to this. This is going to be kind of some of the backbone of your assessment skills, is knowing how some of this stuff works and what some of these ranges are. Vital signs are a major component of your assessment. Usually it will take a couple of minutes to complete. Uh, Most of your patients will have an assessment that includes vital signs. You should really strive to get vitals on every patient within the first couple of minutes of being there. Uh, Vital sign monitoring and obtaining vital signs will help you indicate any potentially important conditions. It will also help you indicate any important trends. So is the patient's blood pressure going down over time? Is it going up over time? Because maybe it's signs of different things going on with them. Uh, Usually it's going to be taken during the secondary assessment after the primary assessment, because the primary assessment is focused on, finding and treating life threats, right? So your vital signs is going to come into place during your secondary assessment when we have time to sit and think and get a little bit more details going on. We start getting our vital signs. So they're considered outward signs of what's going on inside the body. So you have your pulse, your respiration, your skin color, temperature, condition. How are your pupils? What's your blood pressure? What's the blood sugar? Uh, they say oxygen saturation is not a vital sign, quote unquote, but it's pretty much always going to be checked, right? What's their SpO2? What's their oxygen concentration? So your baseline vital signs is always the first set of vitals you obtain. So the first set that you obtain upon making patient contact, that is your baseline set of vital signs. Uh, that's what you're going to compare and trend all of your other vitals you obtain throughout this interaction to. So you may like say your first blood pressure, say it's 120 over 80, perfect, right? Let's say your second blood pressure is 90 over 60. All right. Well, we've trended down significantly. Now we're going to continue trending down, or was that one just a fluke? Is the next one going to be also 90 over 60, or is the next one going to be, 60 over 40? Are we trending in a very dangerous direction? So pulse is a palpable pressure of the heart beating. Everybody knows how to feel a pulse. You can check a pulse on your wrist. It's your radial chulse, right? You can check a pulse on your carotid. That's pulse in your neck, right? You just place your fingertips over wherever that artery is, close to the body surface, and kind of push it wherever it crosses over a bone. What it's going to do is going to cause it to pulsate. You can use it to count the heartbeat. So when you check a pulse, you're going to look for two things: the rate, how fast or how slow, and the quality, how forceful is it? Is it very weak? Is it very intense? How is it? How does it feel? Does it feel just kind of faint, or is it thudding against your fingers? How does it feel? So that's where he's assessing right there, a radial pulse on the wrist. Way you get the rate is you count for 30 seconds, multiply by 2. So feel your wrist, count it out for 30 seconds, multiply it by 2. Your pulse rate, a normal pulse rate for an adult is between 60 and 100 beats per minute. For those of you who are note takers, a normal rate for an adult at rest is between 60 and 100 beats per minute. You need to know that. That is your normal range for your heart rate. Tachycardia is considered anything above 100 beats per minute. Okay, tachycardia is anything above 100 beats per minute. Bradycardia is anything that is below 60 beats per minute. So tachycardia is fast, bradycardia is slow. Everybody got that? During an emergency, it's not always unusual for a pulse rate to be kind of elevated. So somebody's stressed, they're anxious, they're crying. It's not unusual for it to be, between 100 and 140. It's not completely uncommon. We need to try and get a good baseline to get them calmed down, and then go back to that and try to reassess vitals and try and trend it towards a normal direction, right? What are some normal situations that may account for a heart rate that is outside of the normal range? What's some things that may cause your heart to get beating really fast?
You getting scared can do that.
Scared, yeah. What else?
Blood loss.
Blood loss may cause it to slow down, or
Compensation.
it may start compensating. We'll get into that as we start getting into shock. Absolutely. Anybody here exercise? Anybody here
Just
run? Right? Heart rate gets faster when you run. That doesn't mean you're necessarily having a medical emergency, does it? So you got to think about your factors of what's causing your heart rate to potentially be outside the normal range. Now, if they're at rest, having no issues, just sitting on the couch, and their heart rate is 190, problem. Okay. You always
I
got to
was
take into outside factors into account. What'd you say,
I was
Jacob?
also gonna say meditation too as well. I know sometimes people when they meditate it slows their heart rate down.
Meditation. I've never done that, but I'll take your word for
Well, I've never done it either, but it's just
it.
something I've heard.
All right, so when you're assessing pulse quality, you also want to assess the rhythm. So, is it regular? Meaning, is it just on a consistent basis? Boom, 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 or is it irregular? Is the rhythm not constant? So, do you have two beats followed by one beat, followed by three beats, followed by one beat, in rapid succession? Is it kind of irregular? You want to, feel that and take note of that. Feel the force of how the pulse is. So, uh, pulse should always feel strong. It should feel good and solid against your fingers as you're checking it. A thready pulse is anytime it feels weak or thin or just very faint. That's going to be considered thready. Some common locations to take a pulse. Your radial pulse, that's your wrist pulse. It's usually used on patients that are a year and up. Uh, place the first three fingers on the thumb side of the patient's wrist, just above the crease. Take it right there, feel it. You should feel it. Everybody feel it on yourselves real quick. That's your radial pulse. A brachial pulse is usually used on patients that are a year old or younger. That's felt in the upper arm. So anybody that has small children or around small children, you feel in that upper arm, right around where the bicep is. You just kind of push in right there very gently, and you will feel the pulse right there. It's harder to find on adults. There's usually more muscle mass or more fatty tissue or just more, a greater mass around the upper arms in adults. But in a child, it's very thin, very small. You can find a brachial pulse a lot easier than you can a radial pulse. That's where you would find a brachial pulse at. I encourage everybody next time you're around a baby, don't be weird about it, but just kind of casually feel a brachial pulse. Know what it feels like, know how to find it. And your carotid pulse. That's felt along a large carotid artery on either side of your neck. So pulse you check in the neck, that is your carotid. So respirations are how many times are you breathing? It's your respirations, that's your breathing. Your measurement includes both rate and quality. Radial pulse. Feels like that slide should be like back here, not in between these two, but whatever. I don't make this thing. All right, so your respiratory rate is the number of breaths the patient takes in 1 minute. The rate of respiration is either classified as normal, rapid, or slow. So if they're breathing normal, breathing too fast, they're breathing too slow. The normal rate for an adult at rest is between 12 and 20 breaths per minute. You need to remember that. Between 12 and 20 breaths per minute. Patient's age, sex, size, physical condition, emotional state, all of that influences breathing rates. The general normal rate for most your average adult at rest is between 12 and 20 breaths per minute. If a patient's breathing unusually fast or unusually slow, you may have to give them a little bit of supplemental oxygen, try and calm them down, try and coach them to calm down if they're breathing too fast, or encourage them to breathe a little faster if they're breathing very slow or if they're conscious. With respiration quality, there's 4 categories of respirations. There's your normal respirations. That's normal. There's nothing wrong with them. They're shallow, so they're not very deep, right? There's kind of guppy breathing a little bit. There's labored. That's where they're having trouble breathing, they're having difficulty breathing. You notice they're having difficulty breathing. And there's noisy, so you can hear them breathing, you can hear them snoring, you can hear sort of poor lung sound, right? Those are your noisy breathing. If you observe irregular respirations in an unconscious patient, really in any patient, you should report and document it. Take note of any kind of irregular respirations. Count your respirations after you assess the pulse. So check your pulse, count your pulse. And the same way you count your pulse, the same way you get your respiration rate, your respiratory rate. You count the number of breaths the patient takes in 30 seconds and multiply by 2. You assess your skin. So you assess the color, temperature, and condition of the skin. That can provide information on how the patient is circulating. In adult, the best place to assess skin color. Just one second. Sorry about that. So the best place to assess the skin color in an adult is the nail beds, the inside of the cheek, the lower eyelids. What do you think you're looking for there? Let's just take the nail beds. What kind of coloration do you think would be bad to see there? Patient has bluing around that right there. What would that indicate? The patient has bluing around their nail beds, inside of their cheek, lower eyelids. What would that indicate?
Um, they're not getting very well. Since their skin's turning blue around their
Yeah.
nail beds inside their cheeks, they're not getting enough oxygen.
Like you know, oxygen hypoxia, they're not perfusing well, right? So that would probably be some indication to provide supplemental oxygen or supplemental respirations, right? And infants and children, the best place to assess is the palms of the hands and soles of the feet. Looking for the same deal, like for any kind of discoloration there. Patients that have darker skin, you want to check the lips and the nail beds. Same deal for any kind of discoloration, poor coloring. So abnormal skin colors, it's going to be pale, cyanotic, which is kind of the bluish gray, flushed or really red, or jaundiced or really yellow. Those are all abnormal skin colors to take note of.
Jaundice, that's a, a sign of liver failure, isn't it?
Usually related to the liver somehow, yes, sir. So you want to feel the temperature with the back of your hand. Note if it feels warm, hot, cool, or is it ice cold? Generally, if a child is under 6 years old, you want to evaluate capillary refill. So way you do that is you press on the nail bed, the top of the hand and the foot. You want to press on it and release. Note how long it takes for normal painkiller to return. So you want to squeeze it, release it, see how long it takes to return to normal. A normal reading there is less than 2 seconds. It'll be back to the normal color. You assess the pupils. Your pupil is that black part in the center of your eye. In a dim environment, your pupil will dilate or it will expand. In a bright environment, your pupil will constrict. So you want to check and see if their pupils respond. So you want to look for how big are they? Are they real pinpoint? Are they real small? Are they really wide? Are they really large? Are they equal? Are they equal sizes? If they're not equal sizes, that may be an indication of some sort of head injury. Are they reactive? So whenever you shine a light around them, are they reacting to your light? Figure out your baseline size. So figure out what the pupil size was as you approach. Just look at their eyes. Figure out how they look. That's how you assess the pupils. So constricted pupils, we got kind of a red pinpoint going on here. Dilated pupils, you see how they're very large. And you have unequal pupils. So one's pinpoint, the other one's very large. The sign of being under the influence of a topical drug. So sometimes patients go to the eye doctor, they may have one of their eyes dilated, right? Or they may have a head or an eye injury. Something to assess, something to note. Have any questions on that? Comments, concerns, donations, anything? All right. Now we're gonna get into blood pressure. So your blood pressure is the force of blood against the walls of the blood vessels. Your systolic blood pressure is created when the heart contracts and forces blood into the arteries. Your diastolic pressure is what is remaining in the arteries when the left ventricle relaxes and refills. So your systolic blood pressure is your top number. Your diastolic blood pressure is your bottom number. Your normal blood pressure is a systolic of no greater than 120 and a diastolic of no greater than 80. Changes from that usually indicate something pretty significant. Blood pressure is measured with a blood pressure cuff and a stethoscope. That's a fancy word for blood pressure cuff. Cuff should cover 2/3 of the upper arm, from the elbow to the shoulder. So there's your blood pressure cuff. You wrap the cuff around the patient's upper arm. Place the lower edge of the cuff about 1 inch above the crease of the elbow. Place the center of the bladder over the brachial arteries. There'll be little lines right here. You'll line that up over where the brachial artery should run in the arm. Get it secured. Tell the patient what you're about to do. So, hey, it's about to get really tight. Position the cuff and the stethoscope. So get the cuff where you want it. You're going to place your stethoscope right here below it. Right there. You're going to inflate the cuff. So you want to listen and inflate until the gauge reads 30 millimeters higher than the point of the pulse sound or disappears. So you're going to listen for the pulse and inflate until 30 30 millimeters higher from the point where the pressure sound disappeared. There's a little gauge right here. So you're going to listen, listen, listen. Say you heard it until you hear you got to 100. You're going to inflate to 130. Then you're going to slowly release air from the cuff. As you do this, first time you hear a pulse through that stethoscope, you want to make sure you're watching that needle. The first time you hear that, that's your systolic blood pressure. That's your top number. You continue to deflate the cuff. The sound turns to dull, muffled, or disappears altogether. Whatever the needle's at right there, that's your bottom number. That's your diastolic blood pressure. So then you record that. We're going to practice doing this next Saturday as well. If y'all don't have your blood pressure cuffs, make sure you get them. I'll send a link out on Amazon for a cheap set that y'all can bring. Another way you can determine blood pressure is by palpation. So you're going to position the cuff and find a radial pulse. All right. So then you're going to inflate the cuff. You're going to slowly deflate the cuff. So whenever the radial pulse returns, as you're deflating the cuff, that's your systolic blood pressure. The way you record that is, say your systolic blood pressure is 130. You would record a 130 over P, so 130 over palp. You don't obtain a diastolic blood pressure when you palpate. It's difficult to obtain a blood pressure on infants and children that are generally under 3 years old. It's not always the most accurate vital sign on children because you don't have the appropriate equipment, or you don't listen appropriately, or you overinflate or you underinflate. It's just really hard to get an accurate blood pressure on children under 3. More useful ways of determining circulation in an infant is observing. So you look for their appearance, check their cap refill, check their pulse, all that other fun stuff. That's how you're going to generally assess circulation with them. Give a blood pressure monitor. Just position the cuff where it's supposed to be, inflate the cuff, and then record the reading on it, because it will inflate and it will deflate it on its own. Any questions over blood pressure? Y'all are going to practice that till you're sick of it. All right. Your body has to operate at a certain temperature to be able to function appropriately. So your body has a narrow range of temperatures that allows these chemical reactions to take place. Your core temperature is the level of heat inside the trunk of your body. So a normal temperature for a person is going to depend on the time of day, the activity level, the age, where you take the temperature at. We generally are going to take oral or under the arm, so either in the mouth or under the arm. Another reading you're going to obtain with the patient is an oxygen saturation, or an SpO2, or a pulse ox. It's the amount of oxygen that's present in the patient's blood, the amount that can be carried. It's usually measured with a pulse oximeter. It may look something like that, or maybe all in one unit that just slides on a patient's finger. Generally, it doesn't hurt to put a pulse oximeter on any patient. Most of them will also count a pulse for you, even though you should still do it manually as well. But it never hurts to get an oxygen saturation on everybody. So here's some readings you need to take note of. Your normal oxygen reading is 96 to 100%. Mild hypoxia is 91 to 95%. Moderate hypoxia is 86 to 90%. And severe hypoxia is anything 85% or less. Write that down. Go ahead. When reading a pulse oximetry or a pulse oximeter, excuse me, The accuracy of the reading can be affected by shock, hypothermia. So a patient is cold, their fingertips are cold, they may not read appropriately. Uh, Carbon monoxide or certain other types of poisonings may actually cause an inaccurate pulse ox reading because it may cause it to read higher. So what a pulse ox is actually doing is shining a little light through your capillary beds, and it's kind of reading the hemoglobin there. So if carbon monoxide binds to hemoglobin, it mimics as though oxygen was bound to that hemoglobin. So if you have a patient who has carbon monoxide poisoning, you may actually get a pulse ox reading of 100%, even though they are hypoxic. It's not reading appropriately, it's not reading effectively. Any kind of excessive movement may interfere with accurate pulse ox reading. Nail polish, somebody has thick nail polish on, sometimes the light can't shine through it appropriately. So that may interfere with it. Likewise with anemia and hypovolemia. If they have some sort of blood disorder, it may affect the way that reading is coming through. Any questions about pulse ox? A blood glucose meter will identify the glucose in the bloodstream. So if you have any kind of patient who's diabetic or potentially diabetic or unconscious, you want to always make sure you obtain a blood glucose on them. They look like this. They usually come in a little kit. They'll have the strips, the reader, some oxygen preps, some little finger pricks, and everything else that goes on here, lancets. Always all come in sort of little zipper kit like that usually. Local protocol will determine whether or not you can use a glucometer. The state of Arkansas says that EMTs can check a blood glucose. So you can carry a glucometer as an EMT. Monitors must be calibrated and stored according to the manufacturer recommendations. Sometimes these little kits right here will come with a little vial of drops that you have to use every so often to calibrate the machine, make sure it stays right. And most of them say you can't store it in heat or cold. You have to keep it kind of room temperature. The way you're going to use a glucometer is you're going to prepare the device, the strip, and the lancet. So get the device. Most of them will power on when you stick the strip in them. Get the lancet, pull the safety cap off, close the patient's finger with an alcohol prep, form a stick of the patient's finger with a lancet, kind of squeeze it just a little bit, get a good little drop of blood going, stick the strip into the blood, then have the patient pinch on that alcohol prep or put a Band-Aid on it, and then let the glucometer analyze the sample, provide you a reading. A normal blood glucose level is usually between 70 to 100 on most healthy adults. Any questions, comments, concerns, directions? No. Capnography. In the state of Arkansas, you cannot perform capnography readings, which is very dumb, but whatever. We're still going to show you how to do it or what it means. So capnography is the amount of carbon dioxide that's exhaled. It's usually reflected as end-tidal carbon dioxide or EtCO2. Normal levels for capnography is 35 to 45. It indirectly indicates how well the tissues are using oxygen and performing. So it's another effect. It's another tool, kind of like pulse oximetry, to measure how good somebody's breathing. Two ways of really measuring capnography is if you have a patient who is breathing, there'll be a special nasal cannula you can put on the patient that will register it as they breathe in and out. If you're ventilating a patient, then there's sometimes a little plastic collar or a little plastic nub that will fit between the bag valve mask and the airway, and it will have a line that runs off into another little monitor machine, and that will it will read the capnography. Any questions over vital signs and monitoring devices? So that wasn't too long of a lecture night for tonight. I'll post this video here shortly, and I'll also send out a link to Amazon for y'all for some blood pressure cuffs and stethoscopes if you don't have them already. Anybody have any questions before we get off here? Thank y'all.
Thank you, Jake.